This is for the benefit of the final years. I know most of you have had some of your postings curtailed. You might have not been exposed to all the common cases kept for the general surgery exam. So this is a poor substitute for what you should have seen in the wards. So Dr. Sai Lakshmi will be presenting a case of varicose veins, and we'll go through history taking, examination, and how the evaluation would go after you present your case. So we'll start off with the case presentation. Dr. Sai will take over.
Good evening. I'll be presenting the case of a 50-year-old gentleman who is a shopkeeper by occupation, hailing from Alappuzha. So he presented with chief complaints of dilated tortuous veins over his left leg for the past 5 years. There is pain and edema over the lower part of the left leg, noticed for past 2 years. Discoloration and itching over the lower part of the left leg for the past 1 year. History of presenting illness. So the patient was apparently asymptomatic 5 years back when he noticed dilated tortuous veins over his left leg. This was insidious in onset and gradually progressive in nature. He first noticed it over the inner aspect of the left lower leg and gradually progressed upwards up to the knee. The dilated tortuous veins become more prominent on prolonged standing and towards the end of the day, and it reduces on lying down. There is associated history of pain and edema over the lower part of the left leg for the past 2 years. The pain is intermittent, dull, aching type of pain, which aggravates on prolonged standing and relieves on lying down. There is no history of claudication or rest pain. There is also associated history of blackish discoloration and itching over the left ankle and foot for the past 1 year.
I'll interrupt for a minute. So far in the history, it's very important to find out the occupation of the patient, because, as you know, many cases of varicose veins are more common in patients who have to stand for long durations. You find a bus conductor or a lift operator or a teacher or a surgeon for that matter, because we stand continuously for hours together, we are more predisposed to develop varicose veins. And again, Dr. Sai just mentioned that there's no history of claudication pain, no history of rest pain. The pain that is usually associated with varicose veins is a dull, aching type of pain. But whenever the patient complains of severe pain, then you need to consider other possible diagnoses, including a associated ischemic pathology or a neurological pathology. So you need to ask for history that would rule out associated peripheral vascular disease. Continue.
There's no history of fever or ulceration, no history of pain or swelling of the calf, no history of trauma, prolonged immobilization or long distance travel.
What is the significance of asking for history of prolonged immobilization?
I'm trying to rule out DVT, deep vein thrombosis.
So deep vein thrombosis is one of the causes for secondary varicose veins. You can have post-thrombotic varicose veins, and these varicose veins develop several years after a deep vein thrombosis. So the history might not be, along with the history of presenting complaints, it might be even prior to that. So there might be a relevant past history of a major pelvic surgery or an orthopedic surgery 4 years back or 5 years back, and subsequently patient developing varicose veins after several years. And this is because once the deep vein thrombosis occurs and recanalization happens, you find that the valves in the deep venous system get affected, and there is an insufficiency within the deep veins, which then predisposes to post-thrombotic varicose veins. Continue.
There's no history of breathlessness, chest pain, cough, or hemoptysis. No history of abdominal distension, swelling noticed per abdomen, or constipation. Past history, patient has no known comorbidities, no history of surgeries in the past, no history of past medications, no history of prolonged hospitalization. Personal history, adequate appetite, has a normal sleep pattern, bowel and bladder habits are regular, not habituated to drinking or smoking. Family history, there's no significant family history in first degree relatives. So to summarize my history, my patient is a 50-year-old male who's a shopkeeper by occupation with no known comorbidities, who presented with complaints of dilated tortuous veins over the left leg for the past 5 years, which is associated with intermittent dull aching pain and edema over the lower part of the leg for past 2 years, and hyperpigmentation and itching over the left ankle and the foot for the past 1 year.
Carry on.
Coming to general physical examination, patient is conscious, cooperative, oriented to time, place, and person, moderately built and nourished, height of 175 centimeters, weight of 65 kgs with a BMI of 20.2. Vitals, heart rate of 70 per minute, which is regular in rhythm, normal in volume and character, and all peripheral pulses felt. Blood pressure of 134 by 80 millimeters of mercury measured in the right arm in supine position. Respiratory rate of 18 cycles per minute, abdominothoracic type of respiration, and the patient is afebrile. There is no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. Local examination. On inspection, the patient is inspected in a well-lit room with adequate exposure from the umbilicus to the tip of the toes. Attitude of both limbs were observed to be normal. Dilated tortuous veins were noted over the anterior as well as the medial aspect of the left leg, extending from the dorsum of the foot up to the knee. There is hyperpigmentation noted over the lower third of the left leg and the foot. Edema noted over the lower third of the left leg. No ulcers or scars noted. No erythema, loss of hair, dryness of the skin, brittle nails, or muscle wasting noted. The opposite limb appears to be normal.
So you can also mention about any deformities. Find that long-standing varicose veins may present with an equinus deformity.
Yes. Palpation, there is no local warmth or tenderness, no thickened veins palpable. Pitting type of edema is noted over the lower third of the left leg. Brody Trendelenburg test 1 was found to be positive on the left lower limb. Rapid filling was noted from above downwards, which was suggestive of SFJ incompetence. Brody Trendelenburg 2 test was also found to be positive on the left lower limb. Gradual filling was seen from below upwards, which was suggestive of perforator incompetence. A multiple tourniquet test was done, and it was observed that below knee and above ankle perforators were found to be incompetent on the left lower limb. Modified Perthes test was done, and it was found that deep venous system is patent bilaterally. A Morrissey's cough impulse test was done, and this was found to be positive over the left saphenofemoral junction. Fagan's technique was done, and deep fascial defects were felt over areas of below knee and above ankle perforators. Peripheral pulsations were felt bilaterally. There were no palpable inguinal lymph nodes. Sensations over both the lower limbs were intact. Homan sign and Moses sign were found to be negative. I also did a straight leg raising test to rule out any neurological issue with the patient, and it was found to be negative. Percussion, Schwartz test was found to be positive on the left lower limb. On auscultation, however, no buoy was heard.
So a couple of things that we can add here. One, in the inspection, we need to mention very clearly that there were no dilated veins over the lower abdomen. The reason why we are exposing the patient from umbilicus downwards is because you might find that some of these patients may have dilated veins over the groin area, which might indicate that there is a outflow vein obstruction, maybe an iliac vein obstruction, or you find dilated veins extending on both sides from the groin all the way up to the axilla with direction of flow from below upwards, which indicates that there is an IVC obstruction, and these are collaterals that have formed to bypass the obstruction in the IVC, and it ends up emptying into the axillary vein and subsequently into the superior vena cava. So in inspection, please mention that there are no dilated veins, or if there are dilated veins, mention that the extent of veins over the lower abdomen. So that is an important point in on inspection.
So I've actually mentioned it under for abdomen examination. On inspection, there were no dilated veins noticed, no visible mass or peristalsis. On palpation, the abdomen was found to be soft, non-tender, no organomegaly, and no palpable masses. Per rectal examination was done. And
Again, this is a significant systemic examination. We've noticed a habit of all undergraduate students mentioning that systemic examination was within normal limits. That is, it's trying to sweep everything under the carpet. Need to focus on what is important for that particular case. So for example, in a patient with varicose veins, if you're examining the abdomen, one of the important points, as Dr. Sai has mentioned, is the presence or absence of dilated veins. The second is a palpable mass within the abdomen. So you can have a large pelvic mass. It can be a pelvic tumor, or it could be a retroperitoneal fibrosis, which would be obstructing the large outflow veins, either the iliac veins or the IVC. It might be even a pregnant lady with a gravid uterus compressing on the large outflow veins. It's also important to examine the external genitalia in these patients, because one, there may be an associated varicocele in a male, or there may be vulval varicosities in women, which indicates obstruction to the pelvic veins, pelvic congestion.
Cardiovascular system, S1, S2 heard, no murmurs were appreciated. Respiratory system, normal vesicular breath sounds heard, no added sounds appreciated. CNS, no focal neurological deficits. To summarize, my patient is a 50-year-old male, shopkeeper by occupation with no known comorbidities. He presented with complaints of dilated tortuous veins over left leg for the past 5 years, associated with intermittent dull aching pain and edema over the lower part of the leg for past 2 years, and hyperpigmentation with itching over the left ankle and the foot for the past 1 year. And on examination, he was found to have left saphenofemoral junction incompetence as well as below knee and above ankle perforator incompetence. After my history and clinical examination, I would like to arrive at a provisional diagnosis of chronic venous insufficiency of the left lower limb with primary varicose veins, the GSV system, and perforator incompetence. And according to CEAP classification, he falls under C4A, EP, AS, PR over the left lower limb.
Okay. So this is a complete diagnosis, right, including the CEAP classification. I hope all of you are familiar with the CEAP classification. So this is after history and clinical examination. Next, we will go on to how, when you come to your viva, what are the questions that an examiner is likely to ask you regarding this case. As usual, the first thing is how would you proceed with investigations. So when someone asks you, when an examiner asks you about management, please don't jump to treatment first. We need to investigate the patient, because majority of our treatments are based on investigation results and not just on clinical examination. There are exceptions. For example, a hernia. A hernia is mainly a clinical diagnosis, but here you find that the sensitivity of our clinical tests are pretty low. So we would want to confirm our diagnosis with relevant investigations. So what are the relevant investigations that you would do here?
Sir, I would start with all routine baseline investigations, blood workup, which includes CBC, um, uh, RFT, serum electrolytes, PTINR, pre-op serology. Then I would like to confirm my diagnosis of SFJ incompetence and the levels of perforator incompetence using a venous Doppler or a duplex scan of the lower limb.
So when we talk about investigations, it's always better to talk about investigations that would confirm your diagnosis first, and then move on to the other investigations which are done to assess the general fitness of the patient, especially if you're planning to take the patient up for surgery, right? So here, I would prefer it if you would put the venous Doppler scan as a first investigation to confirm your diagnosis. So that would assess whether there is an incompetence at the saphenofemoral junction, right? Whether there's a reflux at the saphenofemoral junction. It can time the duration of the reflux, and the reflux can be graded, right? And it can assess the level of the incompetent perforators, right? And you can mark the incompetent perforators. If you have a short saphenous system involvement, you find that the location of the saphenofemoral junction is very variable. And if you're planning for surgery on the short saphenous system, you would want to identify whether it is at the popliteal junction, below the popliteal junction, or in the lower thigh. So that is another investigation that can be done. So the other important thing that you should assess when you're doing a duplex scan is the patency of the deep veins, because that is a very important factor in deciding whether we are going to proceed with surgical treatment for the superficial veins. On a duplex scan, if you find that your deep veins are blocked, are thrombosed, then we usually do not offer surgery for the superficial veins, because those are the only channels that lead back to the heart. The deep veins are obstructed, right? So that is an important aspect that needs to be checked on a duplex scan. Right, continue. So we finished with investigations to confirm the diagnosis, right?
Yes, sir.
I'd like to add one more thing. In your particular case here, the patient did not have an ulcer, but there are cases where you have patients with varicose veins with an ulcer, and you need to spend a good amount of time describing the ulcer as you would do for any other examination of an ulcer. So you need to mention everything about the ulcer in the history and on examination. So in a patient with varicose veins, what features of an ulcer would tell you that this is venous in etiology?
The edge will be sloping.
Start with the location. The site of the ulcer.
Usually located over the medial malleolus, a few centimeters above, which is typically called the gator's area. And characteristics of the ulcer, the edges of the ulcer would be sloping. There will be surrounding skin changes noted, like hemosidrosis or hyperpigmentation, lipodermatosclerosis.
So you should know about why there is hyperpigmentation, right? What is lipodermatosclerosis, right?
Yes, sir.
So everything about the ulcer. And very often when you have an ulcer, it goes without saying that these patients will also have an enlarged inguinal lymph node. So you need to examine the groin for enlarged inguinal nodes. And then you need to mention about the nodes as well.
Yes, sir.
Right. So investigations over. So then definitely the examiner would ask you about how you did some of these clinical tests that you've mentioned. Cases, if the examiners are free at the time when you're taking the case, it's not uncommon for them to stand behind your shoulder and see whether you're doing the test properly, right? So you need to be prepared for someone observing you while you're doing these tests. So you need to know how to do a Trendelenburg test 1, how to do the second part of the Trendelenburg test, how to do a multiple tourniquet test, how to do a modified Perthes test, how to do a Morrissey's cough impulse test. The questions might sometimes not be how do you do a Trendelenburg test. They might ask you what are the tests that you would do to assess the saphenofemoral junction incompetence, or what are the tests that you would do to identify whether the perforators are incompetent, or what are the tests that you will do to localize the incompetent perforators, or what are the tests that you do to assess the patency of the deep veins. So let's take those questions. What are the tests that you would do to assess the saphenofemoral junction?
Brody Trendelenburg test
Yes,
1.
yes,
Morrissey's cough impulse.
yes.
Schwartz test.
Schwartz test? No, not the Schwartz test. Why the Schwartz test? The Schwartz test is only telling you that there is an uninterrupted column of blood. It doesn't necessarily mean that the saphenofemoral junction is incompetent. So it's a Trendelenburg test 1 and the Morrissey's cough impulse test. What are the tests that you would do to find out whether the perforators are incompetent?
If I want to know the level of the perforator.
No. Whether it is incompetent in the first place?
Modified perforator.
No. The Trendelenburg test 2.
Oh, the Trendelenburg test.
Where do we do a modified Perthes test?
To rule out to see that if the deep venous system is
So the
patent.
modified Perthes test is done to assess the deep veins, nothing to do with the superficial system, right? The perforators are assessed by the Trendelenburg test 2. So you need to know how to do the Trendelenburg test 1, how to do the Trendelenburg test 2. And if your Trendelenburg test 2 is positive, then you need to proceed with tests to identify the level of incompetent perforators. And that is where anatomy comes in, and you need to know which are the levels of the perforators, where do you have these perforators, what are the named perforators. What are the named perforators, Dr. Sai?
Along GSV, there is Dodds, below knee boils, then there is Coffett's perforator and ankle perforators, which are May and Custer, named May and Custer perforators. Cockett's is located at 5, 10 and 15 centimeters from the ankle.
Above the medial malleolus.
Above the medial.
In the thigh again, you may have the perforator and the Hunterian perforator also, right?
Yes.
The below knee, the lower thigh perforator or the Dodds perforator. The below knee perforator or the Boyd's perforator. Okay, so you need to know about the anatomy, right? You need to know the how the great saphenous vein forms from the dorsal venous arch, moving in front of the medial malleolus, ascending along the medial aspect of the leg to enter the thigh, and finally terminating at the saphenofemoral junction. You need to know about the named tributaries at the saphenofemoral junction. Do you care to mention the names?
Yes, sir. Superficial inferior epigastric, superficial circumflex iliac,
The external pudendal,
yes, external pudendal,
superficial external pudendal,
medial and lateral accessory saphenous,
which were previously known as the anterolateral perforator and the posteromedial perforators, right?
yes.
So these are the named tributaries at the saphenofemoral junction, right? So anatomy, you need to brush up on the anatomy, right? You need to know about the superficial veins, the great saphenous, the short saphenous, the perforators, the deep system of veins, and the perforators that connect the deep system to the superficial system, including the posterior arch vein, sometimes the short saphenous continuing into the thigh as the vein of Giacomini, right? So need to brush upon anatomy of the venous system of the lower limb. So these are the questions that may be based on some of the tests that we've described. So the modified Perthes test, right? There's a very common question asked here as to how you perform the modified Perthes test, and examiners are waiting for you to make this mistake of saying that you make the patient lie down, empty the veins, and then perform the test. All the tests, most of the tests in varicose veins, you start off by saying empty the veins. But in modified Perthes test, you do not empty the veins, right? So please stress that point whenever someone asks you about how you'll do the modified Perthes test. The first thing that you say is that without emptying the veins, you tie a tourniquet below the saphenofemoral junction and then ask the patient to walk briskly for a few minutes. And what are you assessing there?
Deep venous system, if it is patent.
So if it is not patent, what would be the test result?
One is patient will start complaining of
It's the patient's symptoms that are most important. Patient will complain of cramping pain, right? So that plus
and the varicosities will become more prominent.
Will become more prominent, right? So that is how you infer that the deep veins are not patent, right? So this is how you do the modified Perthes test. Now, how do you do the Figans test? Then the question might be, I asked you earlier about what are the tests that you do to assess the level of the incompetent perforators. One is the multiple tourniquet test, where you tie
tourniquets
after emptying the veins.
After emptying the veins, tourniquets, multiple tourniquets are tied. One above the knee, that is mid-thigh, below the knee, and above the ankle.
And
then you ask the patient to stand up, look for the filling of the veins. If there is venous filling
between perforators, you know that the incompetent perforator is between those two perforators. And then you release perforator, the tourniquets from below upwards. And you see whether there is any filling, which would again help you to identify the level of the incompetent perforator. So that is one test done to identify the level of the incompetent perforator. What is the other test that you can do?
Figans.
The Figans test, right? How do you do the Figans test?
First, you have to mark the prominent areas while the patient is standing. Then you ask the patient to lie down and empty the veins. Then, after emptying the veins, you try and palpate along the marked areas, and you are trying to look at deep facial defects through which the perforator actually comes out and connects the superficial venous system to the deep venous system.
And the areas where you have defects in the deep fascia correspond to the level of the incompetent perforators, right?
Yes.
What is the rationale behind this test? So normally what happens in a normal individual with normal patent perforators, competent veins, what happens? So as I was saying, in a patient who has a normal venous system, you find that blood will flow from the superficial veins into the deep system through the competent perforators, right? It permits blood to flow only from the superficial to the deep system. And the perforating veins, the superficial system is superficial to the deep fascia, the deep veins are deep to the deep fascia. So the perforating veins have to pierce the deep fascia. And normally you find that there is a very small amount of blood that flows across a competent perforator. So the size, the caliber of the competent perforator is small. So the defect in the deep fascia will be small, and this will not be appreciated when you run your fingers over the skin, right?
Yes.
But what happens when these perforators become incompetent? You find that a large volume of blood then passes across the incompetent perforators into the superficial system. So to accommodate this increase in volume, you find that the perforators become distended, and correspondingly you find that the defect in the deep fascia over time becomes larger, and that is what is appreciated as a defect in the deep fascia when you do the Figans test, right? So these are the two tests that we do to assess whether the level of the incompetent perforators. So in your particular case, you said that you were able to appreciate a below knee perforator that was incompetent, as well as ankle perforators that were incompetent. Right, continue. So that is about the tests. Next, having finished with the tests, having finished with investigations, naturally we need to move on to the next aspect of management, which is the treatment, right? So how would you proceed with treating this patient?
Sir, SFJ incompetence is an indication for surgery. So there are actually two options, either an open surgery.
There might be patients who say, doctor, anything other than surgery. Is there anything else that I can do? Are there medicines that can help?
Yes, sir. But the effectiveness is not actually recorded in the literature, but there are medications which can be given, like flavonoids.
In this particular patient, definitely surgery is indicated. But otherwise, in early cases of varicose veins, there is you can give them a trial of conservative measures, right? Lifestyle modifications. You can start with lifestyle modifications, like
limb elevation. If try and reduce weight, if the patient is, if the BMI is towards the higher end of these patients. Compression, stop.
Avoiding prolonged standing, right? Asking them to take frequent breaks.
Yes, sir. And
With limb elevation. Using either crepe bandages or compression, graduated compression stockings. So these are some of the conservative measures. And then pharmacological interventions that you can try.
Daflon can be suggested, which is a flavonoid and thiosine.
Calcium, dobicelate. These are some of the pharmacological interventions that you can try in early cases, right?
Yes, sir.
But in this particular case, you would advise surgery because your clinical evaluation has documented that there is a reflux at the saphenofemoral junction. We've gone ahead and done a duplex scan. That has also shown that there is a significant reflux at the saphenofemoral junction and the deep veins are patent, right? So that is why you would want to advise surgery, right? So what surgical options would you offer?
There are options of open surgery as well as endovenous laser therapy or radiofrequency ablation.
So time-tested open surgery for varicose veins with incompetence at the saphenofemoral junction is the Trendelenburg operation, right? Yes. Trendelenburg operation. What is this Trendelenburg operation essentially? If I were to ask you to describe it in one sentence, what would you?
It includes flush ligation of the saphenofemoral junction and ligation of its tributaries.
Control all the tributaries of the great saphenous vein at the saphenofemoral junction and then proceed to ligate the great saphenous vein flush with the femoral vein, right?
Yes, sir.
And this is often combined with other procedures like
vein
stripping of the vein. And how far will you strip it?
Up to the mid calf, it means below that.
Usually
upper calf.
Strip just at the level, just below the knee, right? Yes. We stop at the knee. Why don't you proceed and strip the entire GSV? Why not strip the GSV in the leg?
There is a risk of injuring the saphenous nerve, which lies in close proximity to the vein.
Find that the saphenous nerve runs very close to the great saphenous vein in the leg. So when you use a stripper, there is a possibility of causing injury to the saphenous nerve, which would present as sensory nerve, which would present with neuralgic pain, right? And that is one of the leading causes for litigation after vein surgery, right? So we limit our stripping to the knee, right? Only the thigh segment of the GSP is stripped. Other procedures that can be combined with Trendelenburg operation, one is the stripping, yes, short segment stripping.
Perforator ligation.
We can do a perforator ligation. cosmetic phlebectomies. I find that many of these patients seek medical attention only because of the cosmetic uh, issues. You have unsightly blowouts, and these need to be addressed by cosmetic phlebectomies or hook phlebectomies, right? Where long segments of these tortuous veins can be avulsed, right? So these are some of the procedures that are done along with Trendelenburg operation, and this is what we've been doing for hundreds of years, the time-tested open surgery, right? So obviously, the next question would be, what are the newer modalities of treatment or the minimally invasive options for treating varicose veins?
Laser as well as endovenous radio frequency ablation. There is also foam sclerotherapy if we are dealing with smaller veins, particular veins.
So you would need to know the principles of endovenous surgery. Right? What are we doing? We're
basically damaging the endothelial lining of the vein so that the veins collapse and there is fibrosis.
So you're inducing a sterile inflammation, right? Either using thermal energy or using the thermal energy, radio frequency and laser are inducing thermal damage. Whereas if you're using sclerosis, you're using a chemical, right? It is basically it acts as a detergent, right? So what are the commonly used sclerosins?
Sodium tetraethyl sulfate, polydopamine, ethanolamine oleate.
So some of the commonly used sclerosins, and the advancement in sclerosin therapy is
Foam
sclerotherapy, right? Where you can use a
lesser amount of the sclerosant per centimeter. So you're creating foam which
questions here would be, this needs to be done under ultrasound guidance. So that you know that the sclerosin is extending only up to the saphenofemoral junction and not beyond, where it can, spill into the deep venous system and then induce deep vein thrombosis, right? What is the technique of creating a foam?
It's called tesserae technique, where two syringes are used, which is connected by a three-way, and the pistons are pushed in simultaneously, one after the other, to create a foam. This is then induced into the veins through a cannula.
Under ultrasound guidance, right? So these are some of the newer modalities. There are other techniques of treatment like microspherotherapy, the Trivex.
Right.
So these are some of the newer treatment modalities. In this particular patient, you said that the perforators were also incompetent.
Yes.
You're doing a Trendelenburg operation. It is addressing the incompetent saphenofemoral junction. What surgery can you do to address the incompetent perforators?
Perforator ligation.
So earlier we used to do the open perforator ligation. It's called a subfacial perforator ligation, right? So we deal with the perforators below the deep fascia, because above the deep fascia you find that these perforators are multiple and they then join together to form a larger trunk, which then joins the deep veins, right? So if you tackle the perforators below the fascia, you can end up tackling less number of perforators, right? So it's called a subfacial ligation. That involved a very long incision, right? So which was not very cosmetically appealing. So we have a minimally invasive procedure for tackling the incompetent perforators. This is called the SEPS, the subfacial endoscopic perforator surgery, right?
Yes.
So these are the treatment, surgical treatment options for varicose veins, right?
Yes, sir.
So if the patient had an active venous ulcer, how would that change your treatment?
I would have to address the ulcer as well. We'll have to try with daily dressings or something called the discharge surgery.
Okay, so we would first try and get the ulcer healed,
Yes,
right?
sir.
So there are measures to promote ulcer healing. In addition to the usual, cleaning the ulcer, debriding the ulcer, dressing the ulcer, there is a regimen called the Bisgard's regimen. These are the E's of Bisgard regimen. What are the E's of Bisgard's regimen?
Patient education, limb elevation, um, elastic compression bandaging, and
Exercise. Right?
exercise.
You ask them to, walk properly so that the calf muscle pump action is optimized, right?
Yes, sir.
So this is how you would manage a patient with a venous ulcer, the Bisgard's regime. And then once the ulcer is healed and the infection settles, you proceed with one of the surgical options that we have talked about, right?
Yes, sir.
So you should know about what are the complications that can happen after surgery, right? For varicose veins. What are the possible complications? The most common problem is recurrence, right? And what are the reasons for recurrence? We call it revas. Revas. What are the reasons for recurrence after a surgery for varicose veins?
Sir, if we are talking about thermal ablation, there can possibility of a recanalization after RFA or laser therapy.
Yes, the one is recanalization.
Second, in case of open surgery,
The neovascularization, right? That is a important problem that you see after a thorough open surgery, right?
yes, sir.
And then obviously it's due to technical issues where you have identified the GSV. There's a wrong identification. So you might have a prominent anterolateral tributary, right, which is draining into the GSV. So you'll identify the anterolateral tributary as a GSV and the actual GSV as a femoral vein, and you end up ligating the anterolateral tributary flush with the GSV, whereas you're actually leaving behind the dilated GSV and not tackling that at all. So that is a technical failure, or failure to ligate all the tributaries at the saphenofemoral junction, or failure to do a flush ligation. You leave behind a long segment of GSV at the saphenofemoral junction. All of these are reasons why varicose veins can recur, right? So that is one of the complications. The other complications would be, like we mentioned, injury to the saphenous nerve, especially if you extend your stripping procedures to the leg segment, right?
Yes, sir.
Obviously, hemorrhage, especially if you've not given good compression after a cosmetic phlebectomy, right? Or deep vein thrombosis if your sclerosing has extended into the deep venous system, right? So these are all some of the complications that you can encounter after varicose vein surgery. What are the complications of long-standing varicose veins?
Hemorrhage following a trivial trauma. Second is ulceration. A long-standing ulcer can develop there can be malignant transformation of a long-standing venous
You
ulcer.
can have a squamous cell carcinoma developing in a long-standing venous ulcer. This ulcer is called the Margolin ulcer. Yes.
Lipodermatous sclerosis, pigmentation, eczema,
You can have
thrombus,
calcification of the veins.
yes, periostitis,
You can have
equine
deformities at the ankle, right?
Yes.
So these are some of the complications of long-standing varicose veins. So this is very, very briefly about how to take a proper history, how to do a examination, and the way the viva is likely to proceed. Right? I'm sure there might be questions that I've missed out, but this is more than enough to get you through your upcoming examination. So before we wind up, I'd like to thank Sai for coming and helping out with the presentation. Thank you, Sai.
Thank you, sir.
And all the best for your exams. Okay, we'll stop here.